Hello, I'm Matthew Weinstock, Managing Editor for Modern Healthcare. Thanks for tuning into the latest edition of the Checkup. The COVID-19 pandemic has exacerbated an already bleak financial picture for a lot of the nation's rural hospitals. The Chartis Center for Rural Health issued a report last month suggesting that about 46% of rural hospitals are actually facing negative operating margins. That report was put out in conjunction with the National Rural Health Association's annual meeting. And I'm pleased today to be joined by NRHA's immediate past president, Pat Schou. She is executive director of the Illinois Critical Access Hospital Network. Pat, thanks so much for being with us.
Thank you, Matthew, for inviting me to join you with the conversation today and share more information about our rural hospitals and our programs going on and our challenges these days, coming out of COVID and our future.
Right. I do want to we'll get into some of the financials in a minute or two, but I want to start with, we're seeing some states nationwide start to really loosen their COVID restrictions, no masking, no social distancing. In Texas, obviously, they've sort of thrown everything out. Some of these states are very rural, Texas, Mississippi. What are you hearing from your colleagues in rural hospitals and their concerns about potential spikes?
Yes, well, we're excited that, we think we may be moving forward towards a somewhat of a normal thing with loosening some of the restrictions. We still have our concerns because these infection control measures still have to be in place until we get people vaccinated. I'm no different than anybody else. We want to go back to the way life was, but we have to remember that we still have elderly people and people with multiple comorbidities that are still exposed. It's a challenge, particularly for states like Illinois, where I'm from, is that we have border states that have lesser restrictions than we do. So it becomes a challenge for those particular hospitals and areas around the border states is, do we have these restrictions? Do we not have restrictions? And then it's kind of a mixed message for people. But within my colleagues in Illinois, we're staying very much, with what we need to do as far as Illinois following the state guidelines. We feel that we're stronger together that way. And infection control measures have to be in practice. And as soon as people are comfortable, we see the numbers coming down. Yes, we are trying to do that. And I see the hospitals gradually easing some of their restrictions, like they're letting more visitors in, and instead of the front entrances having 2 or 3 people, they might have a kiosk and other things like that. So we're seeing some adjustment, but not nearly to the extreme maybe as other states.
And you reference infection control and some of those things.
Right.
As you look at it from your perspective, both in Illinois and then also as former president of the Rural Hospital Association, what kind of best practices have you seen being shared across some of the rural hospitals when it comes to being able to mitigate the spread of COVID?
Right. What I have loved is that people have shared how they've organized their nursing units, like their COVID care units, and how they've shared those protocols for screenings in the clinics using telehealth. All those things have been wonderful. And I think particularly in our rural community, we're kind of open, in the fact that we will share our information really broadly. In Illinois, within the network that I work, we have monthly calls where we talk about what's going on in each hospital. And we learn that little bit of wisdom, that somebody has in passing that along. But what I just want to add, regarding infection control practices, one of the things that we have seen, and we talk about it often, is that no flu. One hospital told me that last year at this time they had 120 flu patients. This year they've had 1. So, these infection control practices have been helpful, even though we have not necessarily been excited about it because of COVID. However, it's awakened us to, being more careful with hand washing and things like that. So that's a good best practice.
Yeah, we've heard that flu data elsewhere too. Is there something that you think you can attribute that to other than, some of the restrictions that have been put in place?
Well, I think it's the restrictions of social distancing and the washing the hands and the masking and being much more careful. But I also think we've really worked hard over the last number of years to get the flu vaccine out. I think more and more people are taking the flu vaccine. So the combination of all of them, and maybe that's a message or a launching point for COVID in the future, is that we continue to be smart about our infection control practices, whether you're rural or urban or community, whatever it is, and that, we have the vaccination and we protect ourselves and we know who's vulnerable and a little bit more conservative with them.
Right. And so, keeping on that topic of vaccines, we're seeing vaccine hesitancy in some communities on the COVID front. As you talk to your peers in Illinois and nationwide, what are you seeing in rural communities in terms of both vaccines hesitancy, but also the ability to get shots and arms, to get the supplies you need?
Right. Well, a couple of things. With the vaccine, as far as healthcare staff, it's a little bit all over the place. It's about 50–60% of the staff have taken the vaccine, and it's the ages between 20 and 40, particularly in the female population, that are reluctant. They're a little nervous about fertility and the impact of that for childbearing. Not that they're really against the vaccine, as they're not quite sure. Then you also have people that have had COVID and had that exposure, and they're waiting for the 90 days to go off. And then some people have stepped back because they think, well, let somebody else go for it that might need it. As far as the community vaccine, we can't have it fast enough. Part of there's delays within smaller communities because of getting it out. They're having to work through the health departments, and each state is different. And then now we have vaccines going out federally to the like the pharmacies, like the Walmarts, the Hy-Vee, the Walgreens, and all of them, and they're getting their vaccines pretty regularly. But it's just all over the place. It's inconsistency. And the other challenge is if you get a dose, let's say in Bureau County, that's the county I live in, a rural community, and we got 400 doses. Well, if you had people that were vaccinated, a month ago, and they're ready to have the Moderna, well, they're going to take, if you had 200 there, they're going to take the 200. So you finished one group, but you still have 200. So you only didn't get 400, you got 200 finished. And so, we just can't have it fast enough. And we are seeing there are a few people that aren't coming back for their second vaccine, and that concerns us, whether it's a transportation issue or concern or whatever. And so the health departments and the hospitals and everybody have been very creative with trying to get the vaccine out. So, we're still trying to get, essential workers, healthcare, school, and police, and funeral home, clergy, and all these other people vaccinated, and they're doing pretty good. And the medical providers have done a great job of stepping up. But it's that age group between 20 and 40%. And it's interesting, between the hospitals and the long-term care industry, about the same issue is prevalent there too, is that if you have a younger population in the childbearing age, there's still that reluctance to get the vaccine. Now, maybe the Johnson & Johnson with the one vaccine will be easier. We don't know, but we're excited about the 3 different vaccines being available, and particularly the one dose. I had one hospital CEO shared with me, and it's no different than colleagues across the country, is that, gosh, if we have plenty of vaccine in the near future, maybe we'll be able to, if somebody comes as an inpatient, they haven't been able to vaccinate, we can get them vaccinated. We don't have to call them back. The good news also is that I credit the health departments and the national system for having a common place to record all the vaccines and to make sure that people can go from one area to the other and that information is there. So, there's some good things that have happened. So that's kind of really where we're at. We've got still working on our essential workers, rolling out to more people, trying to get elderly in to get them vaccinated. And we still have struggles, particularly in our rural areas, getting enough vaccine. And there's just not enough available. And then if you're doing the 2-dose, it makes it challenging because you got to get people back, and you're not tackling the whole population issue.
Right, right. I want to ask too, Pat. We're coming up on a year now of being under lockdown, of COVID really being in place. The workforce across the board has been stressed. Rural hospitals already have challenges getting staff and being able to staff up. Just give us a sense of what it's like for rural workers these days, and a year of this, and how do you build, going into 2021, where maybe there's sort of a light at the end of the tunnel here? How do you start to build up that staff morale again?
Yeah, well, it has truly been one of the biggest challenges is staffing, and doing your budgets. Think about the hospital's CEOs and the finance people trying to budget how much staff do you need and so forth moving forward. But step back into the fall when we really had that second outbreak. It was kind of a real difficult, very, very difficult time because we couldn't find enough staff to fill the gaps, and rural hospitals were calling agencies and they were wanting $150 to $175 an hour for a nurse, and that's not sustainable. You can do that for a couple of shifts, but you can't sustain it that way. And so I'm seeing not only in Illinois, across other areas, they've had to be somewhat creative, offering staff a little extra bonus if they would pick up an extra shift, and trying to work within the system as much. They just couldn't compete with the staffing agencies. And it was hard because the tertiary care centers, we had trouble with transferring patients. We had patients that in our rural hospitals that needed to go to tertiary care, not necessarily for COVID, but for other situations, cardiac, they need a cath and things like that. And those tertiary care centers, the resource teaching centers, whatever, they had staffing issues. And so they couldn't take our patients because they were down in staffing. And so it was just a real circle of almost a no return. But we did weather through it. And I had a conversation with a number of CEOs recently, and the staffing has stabilized a little bit. But they all said they have open positions. They all have open nursing positions. They all have open lab or imaging positions. And so it really heightened. We got through it through, patchwork. But long term, like you indicated, Matthew, we're going to have to really beef up our health population, healthcare professionals, because you're also dealing with a number of our baby boomers, those
Right.
60-year-olds, as they get through this, maybe they stayed on an extra year or two. And, as we get back to what we call normal again, where we have, business as usual, we're going to need that. So we're behind, and, there's a constant push out with workforce development, not only in Illinois and other states. And I know nationally, I think there's probably money in the upcoming COVID bills for, workforce and things like that. We have to continue, but we're kind of sometimes with rural, you're down the road there, and
Yeah.
the training's done in larger facilities, and so we have to build that connection early on to get people to come back, and but we can pay somewhat competitive, but we couldn't pay those agency prices there for a while.
Right. And so this sort of leads into the next question. You've referenced the COVID stimulus bill that, as we talk, is moving its way through Congress. Um, there is money in there for rural healthcare, and I don't want to focus specifically on what's in there, but that seems like a sort of short-term patchwork uh, fix for some rural hospitals that are struggling. But again, as you think about going into 2021 and into even 2022, so many rural hospitals are struggling. More long term, once we come out of COVID, what does this mean for the future of rural hospitals? How do they have to pivot at what they're doing
Yeah.
to sustain themselves?
Well, there's a number of things that we learned from COVID. One is that telehealth is going to have a great influence, telemedicine, and how do we in rural do it creatively? I think it opens the door for specialty care and keeping some things local, but it also opens up for competition. Okay, so how do you compete and stay and keep people locally? And I think we're looking at new ways of providing services. CMS hinted at hospitals without walls. So how and locally can we care for patients? So I think we're going to see more of the growth of the outpatient business, and how can we continue to change the delivery of care? I know on the last bill in December there was the rural emergency outpatient hospital model out. This provides funding for rural hospitals to help them, evaluate their position and see what financially need. I know Senator Durbin and Langford last year introduced legislation that would open up the doors to allow people get back into the critical access program, some what we call tweeners hospitals that are a little bit larger than critical access and actually downsized, could be eligible, but they can't because of distance requirements. So we have to look at different strategies. Hospitals themselves have to rethink their strategic plans. I mean, I think if you did a strategic plan 2 years ago, you should be rethinking it and look at what you can deliver for the future. I think we have to be creative as rural hospitals. We can't rest on what's been done before. And we have to look at how do we take advantage of technology? How do we get better at care coordination? How do we figure out how to send the patients for their care and then come back? And that was one thing that I liked about the COVID, is that many of our small hospitals build good working relationships with their larger tertiary care centers. In other words, they sent patients there, and the tertiary care centers no longer could care for a COVID patient or other, and they sent them back to the rural hospitals to their swing bed programs. And so we were able to better utilize beds and deliveries of services. So if we can build on those things, we can start to make them viable. The other thing with we hope with the bill is that there's stimulus for rural communities, because it's not only the hospitals have to be creative, but we also have to have jobs and places to live. And I'd like to say rural might be the new place to come and live, because we have great schools and housing and things like that. But in a rural community, you have to have good workforce, you have to have good health care and good school systems. So they all go hand in hand. And so if we look at the future, the community hospitals have to be talking, whether they're part of a system or not, with their local community. How do they sustain themselves and rethink their strategic plan?
Yeah, I think that's interesting to think about. If you did a strategic plan a year or 2 years ago, it's time to totally reevaluate that. Pat, there was some really good information in there. We definitely appreciate you taking time. We know that there's a lot that we could talk about and unpack
Oh,
in
we can
rural
go for
healthcare.
hours.
Right. So we'd love to come back and talk to you in the future about the state of rural hospitals, and particularly critical access hospitals too, which
Yeah.
I know you're very much involved in. So, but thank you for taking some time today, and please stay safe.
Thank you for the honor of speaking with you today. Take care.
Thanks. And I'm Matthew Weinstock with Modern Healthcare. Be sure to come back next Monday for another edition of the Checkup.